Right now, globally, we see roughly 3.5 million IVF cycles per year. There are 200 million women dealing with stress urinary incontinence and up to 900 million women facing postmenopausal vaginal atrophy. Yet despite those massive numbers, the standard options for these conditions leave a vast treatment vacuum. Patients are often stuck choosing between interventions that are limited in efficacy, highly invasive, or come with significant hormonal risks. Enter platelet-rich plasma, or PRP. It presents a unifying biological theory. If we concentrate a patient's autologous growth factors and inject them into failing reproductive tissues, we might safely trigger regeneration. Because gynecologic PRP operates entirely in a cash-pay, non-FDA-cleared landscape, the marketing often outpaces the science. To separate medical hype from biological reality, we have to ruthlessly grade the clinical evidence. The largest data set for PRP focuses on IVF patients with a thin endometrium, specifically an endometrial lining below 7 millimeters. This structural deficit prevents adequate receptivity, accounting for about 2/3 of failed embryo implantations globally. This chart visualizes the pooled data from a major 2024 meta-analysis. In patients with a thin endometrium, targeted PRP infusions effectively double the clinical pregnancy rate and show a comparable spike in live birth rates. The data is strong enough that a 2025 network meta-analysis ranked PRP first among all intrauterine infusions, placing it ahead of standard alternatives like GCSF or HCG. But we must look at the exact wording in clinical reviews. Cochrane rates the certainty of this evidence as very low. Importantly, the only low-bias trial found absolutely no benefit for patients with normal thickness endometrium. The conclusion here is highly specific. PRP is not a magic, general-purpose IVF enhancer. It appears to be an effective intervention only when a structurally thin endometrium is the exact biological barrier preventing pregnancy. Transitioning to stress urinary incontinence, we find our first rigorous proof of concept in a 2024 landmark double-blind randomized controlled trial by Grigoriadis. This diagram shows the key success metric from that trial. At 6 months, the PRP group achieved a 32% subjective cure rate, compared to just 4% for the sham treatment. However, there is a stark clinical failure hiding behind that subjective improvement. When measured objectively by standard 1-hour pad test criteria, 0 patients in the trial achieved a complete cure. The protocol data reveals a strict dose-response reality. A separate trial by Ashton showed that single injections completely fail. Multiple treatments are required over several weeks, and even then, the clinical outcomes remain vastly inferior to a surgical mid-urethral sling. For stress urinary incontinence, PRP is not a definitive cure. Instead, it serves as an emerging, autologous alternative, exclusively for women who decline surgery or are poor candidates for the operating room. The application with the most actionable clinical narrative is for the genitourinary syndrome of menopause, or GSM. This is a severe crisis, specifically for survivors of estrogen receptor-positive breast cancer. Standard adjuvant therapies, like aromatase inhibitors, actively suppress estrogen and heavily worsen GSM. The pain and tissue atrophy become so severe that 20% of survivors actually abandon their life-saving oncology treatments. Look at the trajectory on this graph from the 2025 Ein-Shams randomized controlled trial. Over a 4-month timeline, PRP treatments nearly doubled the female sexual function index scores, taking patients from a baseline of 9.7 up to 19.0, all without the use of hormones. Additional data from Hersant in 2018 corroborates this, showing that PRP interventions improve vaginal health indices enough to cross the clinical threshold, moving patients out of atrophy and back into healthy tissue states. In breast cancer populations where standard vaginal estrogen carries a theoretical oncologic risk, PRP acts as a vital, non-hormonal lifeline, restoring tissue by driving fresh neovascularization to the vaginal mucosa. We now pivot to the most controversial claim in the field: the idea that PRP can provide ovarian rejuvenation for women with poor ovarian response or premature ovarian insufficiency. Early excitement for this application was built entirely on uncontrolled pilot data. Clinics were injecting ovaries and reporting resumed menstruation, mistakenly attributing spontaneous natural fluctuations in ovarian function to the PRP itself. To test these claims, researchers designed 2 definitive multi-center double-blind trials in 2024, the Baroneccia study and the PROVA trial. pitting PRP directly against proper controls. The results in the data are devastating for the rejuvenation claim. Euploid blastocyst yields were completely identical between the two groups. Worse, as highlighted in the Baroneccia trial, the clinical pregnancy rate actually dropped in the PRP group. Sticking a needle into an ovary causes mechanical disruption that may briefly recruit a few existing follicles, but the biology is clear. You cannot reverse oocyte aging. Based on the highest quality evidence we have, the term ovarian rejuvenation needs to be eliminated from clinical practice. To understand how PRP works, look at this blood vial cross-section. The crucial regenerative drivers, IGF-1 and HGF, reside primarily in the liquid plasma layer. Standard processing fails to concentrate these, yet IGF-1 is the central engine required for tissue repair. This biological concentration problem is exactly what systems like the Swiss Concept PCX ultrafiltration device were engineered to solve. Instead of just spinning the blood and discarding the plasma, the PCX ultrafiltration process captures and concentrates those plasmatic proteins in fibrinogen. This creates a denser, cross-linked scaffold that releases growth factors over a sustained period. True regenerative success in gynecologic tissue relies on capturing the specific plasmatic proteins that drive targeted healing, rather than just tallying a high platelet count. We do have to state the scientific caveat clearly. The protein enrichment advantage of systems like PCX is biologically coherent and supported by in vitro research, but it currently remains clinically unvalidated against standard PRP in published head-to-head gynecologic trials. The verified clinical landscape shows that PRP is highly promising for specific endometrial barriers and breast cancer survivors, offers a partial step for stress urinary incontinence, and is definitively ineffective for ovarian aging. By discarding unproven hype and rooting our protocols strictly in peer-reviewed data, we can safely navigate the very real frontiers of reproductive regenerative medicine.